Oh, thank you very much for having me. Of course, I would much rather be with you in Chicago, but I'll take this for second best. So I'm going to talk with you for the next 40 minutes or so about how we can best keep people with cirrhosis out of the hospital, and I hope to have time for discussion. I have some conflicts of interest, and the one that's pertinent here is that I had done some consulting for the maker of rifaximin, and they had funded some of my studies. So I'll remind you of that when that's important. And I also have some contact information up at the top right. So I wanted to center our time together in the motivating statistic behind this field, which is something that you may already know. People with cirrhosis are readmitted to the hospital frequently. They're frequently hospitalized. And when I meta-analyzed this topic, I found that rate is 1 in 4, but it's a higher rate commensurate with the degree of decompensation. So the sicker a patient, the more likely they are to land in the hospital. And this is a problem because once a person ends up being hospitalized, they are liable to find themselves in a revolving door of repeated hospitalization, where each additional day spent in that hospital bed renders them more and more frail, more and more susceptible to complications, nosocomial and otherwise. This has costs. Those costs are financial. We're spending billions of dollars on inpatient medicine for patients with cirrhosis, and 1 in 4 of those dollars are attributed to readmissions, and those costs are personal. Every time a patient with cirrhosis is hospitalized, it increases their risk of death, adjusting for their complications and MELD score. So we should do something about it. And the way that we should learn about this is starting with the things that don't work so that we can understand what would work and the mechanisms for it. And then I'll close with a few minutes on some of the things that I've been keeping myself busy with over the last year that would constitute what I would call some new insights or directions. So, when it comes to cirrhosis and outcomes, people tend to immediately leap to gaps in quality of care. And the hypothesis is that if we're doing the right thing to or for patients, then their outcomes should improve. And one of the most pressing outcomes that is before us is this risk of hospitalization and 30-day readmissions. So people like my friend, Dr. Ronnie Gowie at Bay State Hospital outside of Boston, he believed that if we could just get patients with cirrhosis to have a diagnostic paracentesis when they're admitted, that's a quality metric. If they're bleeding, they should get antibiotics, timely endoscopy, and octreotide. These are quality metrics. And he hoped that if you did those things, it would reduce the risk of 30-day readmissions. Now, how he went about doing it was that he consulted himself on every single person with cirrhosis that came into the emergency room at Bay State Hospital. This was a tremendous amount of work for somebody without any funding to do so. And unfortunately, it was not associated with any improvement in 30-day readmissions or in-hospital mortality. So it's a lot of work for one person to do. Now, a better adaptation of this concept comes from Dr. Archita Desai while she was at the University of Chicago across the street. Now, instead of consulting herself on every single patient, they actually reorganized the way that care was delivered for people with cirrhosis and ascites, such that every single person would end up on the same floor, cared for by the same hospitalist medicine service. And each and every day, there was a schedule where the gastroenterologist would round with the hospital medicine team. Now, this was associated with improved quality metrics, improved time to paracentesis, and for people that were diagnosed with spontaneous bacterial peritonitis, they were more likely to get albumin infusions, which prevent the development of hepatorenal syndrome. Unfortunately, those changes were not associated with a reduction in 30-day readmissions. And sort of taking this to its conclusion, we asked the question in 2 national data sets, me and Dr. Marina Serper at the University of Pennsylvania. We combined all of the data that she has under her control at the VA and all of the data that I have in a commercial claims database, everybody with United Health insurance. And we asked the question, what happens to readmission risk and mortality when a patient receives a gastroenterology consultation within the first day? After all, this is probably the easiest way to close gaps in knowledge about quality metrics. Have an expert consultation within the first day of admission. And unfortunately, what you see is while readmission risks are a little bit lower in the VA, they are balanced by a higher rate of mortality, at 90 days. And when you do competing risk analysis, you find that GI consultation is not associated with an improvement in 30-day readmissions in the VA or in the commercial claims database. And so if this was simply about the things that we were doing to patients, then this is not the way, then it's not going to improve 30-day readmissions. We have to focus on the specific drivers of readmission and hospitalization risk in order to keep people out of the hospital. And I'll summarize what I've learned from a variety of studies, including this one, from basically a nationalized data set of readmissions from 6 of the most representative states in our great union. And I found multiple factors that were associated with an increased risk of readmission that I've summarized for you in this highly scientific formula, which is that readmission risk goes up with the presence of hepatic encephalopathy, the presence of ascites, particularly refractory ascites, things like requiring multiple paracentesis, hyponatremia. And those effects are compounded by, exponentiated by active alcohol use. And so if you're going to keep someone out of the hospital, you have to go after these factors. Now, how are you going to do that? When I was an intern, I was very excited about this concept of quality improvement and readmission risk. And at the time, Atul Gawande had just published a checklist manifesto. Everybody was super excited about checklists. And I think even today, if you ask people, like, how are you going to improve quality of care? They're going to reach for a checklist. This is the lowest hanging fruit. But think about the lived experience of doing a checklist. First, you have to agree what goes into it. Sometimes the evidence base is there. Now, then once you have your items, you got to get people to do it. And this means you got to email them, you got to check it up on them, you got to round with them, you got to make sure that they're doing it. And this can feel like a conversation up front, and then eventually it devolves into begging, or depending on your perspective, harassing the frontline users. And if you're not careful, the process of trying to get adherence to, compliance with a checklist will lose the hearts and minds of the frontline providers on whom you depend to execute the elements of your very well thought out checklist. Now, I developed my checklist to do a few things. The first is that I wanted to make sure that we were treating SVP correctly, that is, giving the appropriate dose of ceftriaxone 2 grams daily. I wanted to make sure that everybody who had SVP got albumin to protect them from HRS. I wanted to make sure that they were getting heparin prophylaxis for DVTs, because despite their elevated INR, they are at increased risk of DVT. But I was most interested in reducing readmission risk due to hepatic encephalopathy. And I had noticed 2 things. The first is that when a person was admitted to the hospital with HE, I would write for 20 cc's of lactulose TID, titrate to 3 to 4 bowel movements daily. And of course, that's a maintenance dose that someone takes on the outside at home, but it's not the dose that you need to wake a person up from being untunded from encephalopathy. And so what I found was that the best nurses in the hospital were giving extra doses of lactulose and coming back to me later and saying, would you write for extra orders to cover me for what we did? And I found that patients were waking up a lot earlier. And so the plan was to universalize this goal-directed therapy for encephalopathy, giving extra doses of lactulose Q2 and titrate that dose and frequency to the Richmond Agitation Sedation Scale. Also, when I was an intern, there was a New England Journal paper that established that a drug made by Bosch Health, who I had a conflict of interest with years later, called rifaximin. And rifaximin was approved by the FDA for people who had a breakthrough episode of HE on lactulose for the purpose of reducing readmission to the hospital. So I lived in Massachusetts, and we could give it to everybody because that's how Mass Health was designed. And so we universalized the use of rifaximin. We started with a checklist, nobody did it. And then I was gifted with the opportunity of rolling each of the elements of that checklist into the electronic ordering system, whereby when you went to order lactulose, the computer asked you, are you treating overt encephalopathy? And then it preset the dose and frequency of lactulose and reminded you to give rifaximin. The checklist was not associated with a reduction in readmissions, but that electronic phase was associated with a 40% reduction in the risk of 30-day readmissions, adjusting for the suite of confounders that are associated with readmission risk. And when people came back to the hospital because they were still readmitted, albeit at a lower rate, it was not for encephalopathy, but things that were off target: infection, ascites, bleeding. I later looked at a data set from Medicare. So this is all Medicare enrollees who had hepatic encephalopathy. So this is about 45,000 people, roughly most of them over the age of 65, who had HE and had been alive for at least 90 days. And I asked the question, what is going to drop readmission risk overall? And my two main exposures were rifaximin use and gastroenterology consultation. So it turns out that seeing a gastroenterologist doesn't keep you out of the hospital overall. It's associated with a slight increase in hospital days, but a slight decrease in 30-day readmission. So the rapidity of rehospitalization is actually decreased when you share your care, at least with somebody who has the means to address your complications in the outpatient setting. But what is associated with a reduction in hospital days, including 30-day readmissions, is rifaximin. So this is a drug where there is no chasm between efficacy and effectiveness. It is a drug that works just as it was said to work in the registration randomized trial. And that is how we reduce overall burden of readmissions. Now, it's not going to work unless you give someone lactulose first. And so we have to focus on the basics. This is a graph from the NAC-CELD consortium. So this is a group of hospitals which constitute probably the finest liver transplant and liver failure units in North America, led by Dr. Jaz Bajaj, who will come up again and again. And what he finds is that even in these great hospitals, about half of people who were hospitalized for HE do not go home with a prescription for lactulose. And so on your checklist for how you discharge somebody, it should include evidence-based medicine, but it has to include the simplest, lowest hanging fruit in HE therapy, which is lactulose. There's a lot of ways that we can improve care, and making sure that someone has access to the building blocks of adequate HE care on discharge is essential. So I did a qualitative study where I interviewed 20 people who survived a readmission for HE, and I asked them, why? Why do you think that you were readmitted? And they told me that their loved ones lack the skills to recognize early HE. By the time they're calling for help, the patient is already obtunded. It's too late. You can't intervene. You can't give an extra dose of lactulose. So we need a tool to do that. They complained about access to medications, rifaximin both because it's egregiously priced, and lactulose because they weren't given a prescription for it and they didn't know who to call. And of course, lactulose is no fun. It causes abdominal pain. It causes diarrhea by design. And so they have problems with lactulose, but some of these can be addressed. We can address the abdominal pain by giving anti-gas type medications. We can change the formulation of lactulose. All of these things are important to address with patients ahead of time in terms of education, but also in terms of troubleshooting. So HE, if you have to go after one thing, is where the money is at. But if we want to reduce the burden of admissions more globally, we have to look at systems of care. So imagine that you're a patient who's just discharged with HE, and you still had some confusion when you went home. So your discharging intern did a great job and got you early post-discharge follow-up with your PCP or your hepatologist. And so you're able to make it to your visit, but your caregiver is saying he put his keys in the microwave, he's stumbling all over the place, Sounds a lot like this person is in the midst of a re-decompensation with HE. So what's your doctor supposed to do on a Monday, let alone a Friday at 2 p.m.? They're going to see this person who looks pretty sick, and the first thing they're going to do is they're going to send them right back to the emergency room, because the path of least resistance for handling these things safely is readmission. So it turns out that early post-discharge follow-up within 7 days is associated with an increased rate of 30-day readmissions. Now, in contrast, this was a study that was done from across the VA, led by the undisputed leader of quality improvement in cirrhosis, Dr. Fasiya Kanwal, where she showed that this early follow-up was associated with readmissions, but it was also associated with a reduction in mortality, because hospitalization is a great way to take care of sick patients. But I have a feeling that we can have it both ways. We just need to be able to empower clinicians to handle those conditions in a safe way in the outpatient setting. So there are a few people that have tried to get at this. So WIG in Australia, they did the only randomized trial in this space. And they took people who were being discharged from the hospital with ascites, and they randomized them either to standard of care, which is post-discharge follow-up and a pat on the back, I hope to see you there, or a chronic disease management program, where they got standardized teaching about lactulose and the ins and outs of it, diuretics and how to weigh yourself and when to call. But they also got post-discharge phone calls and even a home visit. So what happened? The intervention was associated with an increase in liver-related hospital days and unplanned admissions. And why do you think that is? Because it's the same thing as an early post-discharge follow-up. You send someone to the house and they see that you're putting your keys in the microwave, that you're stumbling all over the place. What are they going to do? They don't feel safe managing it at home. They're going to send you right back to the emergency room. Early follow-up is an excellent way to capture decompensations, but it does not necessarily include the tools to manage them. So still, some people believe that one of the problems with this is that if you just set up this phone call or this visit within 7 days, it's just not frequent. It's not close enough monitoring. So if only there was an app for that, where we could monitor someone continuously. Dr. Bajaj, again, develops an app. And that app does a variety of things. It tests cognitive function. It tracks medication adherence. It asks about daily weight. It asks about things like melanin. And what it was associated with, no decrease in overall readmissions. But there's problems with this, in addition to its lack of efficacy. The first one is that these apps are going to generate a ton of information, and you can't fall asleep at the wheel here. People are going to be telling you about falls, about melena. Someone has to be there to monitor it. And because it's transmitting so much information, you have to be able to sift out the signal from the noise. And in this model, the person who's confused might not be the patient. It might be you. And when you'll react to all of this information, you may just as soon send that person right back to the hospital from whence they come. But before you think that you can tinker with these apps to make them better, we need to think a little bit more about feasibility. So this is Dr. Jeremy Louis Saint. He's a fellow that works with me, will be transplant fellow in New York next year, will probably change the game for cirrhosis care delivery. And he was very excited about apps, and he thought that maybe the main issue here is that patients with cirrhosis, they lack comfort with acceptance of technology. And he found a validated survey which grades technology acceptance and shows that it's quite variable, and people who have low levels of acceptance are going to be less likely to use apps in other health fields. So he goes to all of the patients in my clinic and he gives them this survey, and lo and behold, they give a score of 61 out of 100, which turns out to be a higher level of technology acceptance than in most chronic diseases. This is a little bit surprising. So he doesn't have a population health-based app, but he has the app that Dr. Bajaj developed to screen for cognitive dysfunction called the Encephalopathy Stroop. Stroop, you can download it from iTunes and use it to grade cognitive dysfunction in cirrhosis. It's cool, but before you do it to a patient, you gotta do it yourself. So he used that as a model, And so he graded everybody's acceptability. They were all super accepting of technology. And 2 out of 3 people, they said, I'll download it. But 1/3 said they're not interested in another app already. We have a problem. Now, how many of the people that said they were willing to download the app actually downloaded it? Another 2 out of 3. So we lose another third. Why weren't they able to download it? Because they didn't know how to work their iPhone that their kid gave them, or they forgot their iTunes password. And then of the 30 people who actually downloaded the app, how many of them actually used it after we monitored them for a couple of weeks? And in this case, it was just 1 in 3. So in an intention to treat way, only 12% of the candidate population of patients who we want to monitor are able to use these apps. I'm not sure this is our solution. So the gold standard in this field is called the Care Management Checkup. And this is a program that was pioneered by Mirando et al. From Italy. And this is what they did. They took patients who were being discharged from the hospital with decompensated cirrhosis, and they assigned them either to the Care Management Checkup or standard of care, which is, again, post-discharge follow-up, hope to see you there. So in the care management program, there was post-discharge phone calls, but this is the difference. If the person calling the patient didn't like what they heard, they had the opportunity to park that patient in a so-called day hospital, a dedicated room within the clinic, where that patient could be observed by a skilled team of nurses and clinicians who know what a patient with decompensated cirrhosis looks like, and they don't just get scared and send them to the emergency room. And if they had symptomatic ascites, they could do a paracentesis. They did cognitive testing because they knew that encephalopathy is associated with a risk of readmission. And if they didn't like what they saw, they would increase lactulose, they would start new treatments. And unlike any other program in the history of this field, they linked these people to effective relapse prevention for substance use disorder. If you're actively drinking, you're not going to follow instructions. If you're actively drinking, your liver function is going to get worse. And this group intentionally linked the patients to psychotherapy and pharmacotherapy for their condition. The results were an improvement in overall survival, where the dashed line is survival for the control arm. And it started to happen around 30 days. So this is a highly plausible mechanism. What they find over the ensuing year is that there was a reduction in 30-day readmissions, a reduction in mortality, and it happened at lower global costs because you're avoiding that big ticket item, the hospital bed days. Now, this is a slam dunk. It obviously works. I've tried to do something similar, and I'd be happy to discuss that experience with you later, but it's really hard to do in the United States because of the way that our care is financially structured. So even though this hasn't been repeated, there are clues within this program that can be easily generalized. So the key one is about the management of outpatient ascites. So this is a study from Hudson. They looked at the United Kingdom. So their population was everyone who actually died from cirrhosis with ascites. And they looked back over the prior year and asked, how much money did we spend on them? How many days did they spend in the hospital? And was the delivery of care associated with each of those outcomes? So it turns out that in the United Kingdom, if you have symptomatic ascites, you have 2 options. You can go to the emergency room for a paracentesis, or you can call up a day case unit and ask for an outpatient paracentesis. But the number of those units is actually variably dispersed throughout the United Kingdom, and it means that there are people who just don't have access to outpatient paracentesis. But if you look at across the population, the proportion of paracenteses that are performed in the outpatient setting is associated in a dose-dependent fashion with decreasing healthcare costs, decreasing days spent in the hospital. So how you operationalize this is simply to say that you have a slot at 12 o'clock every day that's reserved for urgent paracentesis. And if you can create that kind of redundancy into your program, you will keep people out of the hospital. The key takeaways from this section of the talk are that if you want to prevent hospitalization, you treat HE, you make sure that they're on evidence-based therapy and that they have prescriptions for lactulose when they're going home. You make room for paracentesis because an admission to the hospital for ascites is definitively low value, and you treat alcohol use disorder. You link people to care. So I have some newer insights that have been accruing to me over the last year or so, and I wanted to walk you through some of these. And the first one relates to what kind of provider ought to be involved, or how many providers ought to be involved in the care of people with cirrhosis. So the first idea, which was gifted to me by Dr. Shirley Cohen, she's an IBD-ologist, but she's very interested in concentration of care. So in general, someone can have their care, concentrated in the hands of one provider for their condition, or split amongst multiple providers. In some places, this is called fragmentation of care, and the opposite is concentration of care. And the literature is pretty consistent that if you have care that's concentrated in the hands of one person, your diabetes outcomes are improved, your hypertension outcomes are improved. And so is this true for people with cirrhosis? So it turns out that cirrhosis is actually special, and it does not follow that same rule. Because what happens is that people whose care is actually equally shared amongst their primary care doctor, their transplant hepatologist, and their local gastroenterologist, those people's outcomes are optimized. It's associated with reduced overall costs, reduced overall mortality, and reduced days spent in the hospital, including 30-day readmissions. So when you look at concentration of care in terms of two metrics, either continuity of care or concentration in the hands of one particular provider, it is people who have the highest concentration of care who have the most amount of 30-day readmissions, which means that in order to take care of a person with cirrhosis effectively, it requires collaboration, it requires extra consultation, and it requires availability. So I operationalize this concept by making my cell phone available to all primary care doctors to get at improving the qualitative aspects of collaboration in care. Now, getting at this question about who should be taking care of people with cirrhosis, I've been very interested in the role of advanced practice providers because, again, my experience is that APPs, nurse practitioners, PAs, are more thorough and more likely to get things done than clinicians. Physicians. This is my bias. So I looked at United Health data. And in that data set, I have about just under 400,000 people with cirrhosis. And just under half of those people had been seen by an advanced practice provider at some point in their care. These are super sick people, and people who are seen by APPs, they're not that much sicker than patients with cirrhosis who are seen by physicians only. They have the same burden of comorbidities and hepatic encephalopathy and ascites and the like. So we did a natural experiment where we looked at what happened to people who were followed for 2 years, and in the middle of those 2 years, they saw an APP for the first time. So compared to the first year, in the second year, patients were more likely to be screened for liver cancer with an ultrasound. They were more likely to get an endoscopy to screen for varices. And if they had a discharge for encephalopathy on lactulose, they were more likely to receive rifaximin when they saw an APP. And if you look at over time, it's sort of like a dose effect longitudinally, that the longer that a patient sees an APP, the more cumulative liver cancer screens they get, the more cumulative variceal screens they get, and the fewer 30-day readmissions they experience. So I can't tell you exactly why this is happening, but we all know that there are certain providers that are going to be better at educating patients, better perhaps because of the way that they were trained. There are certain providers in our practice that are more likely to fill out the paperwork required for the completely laborious, sometimes ridiculous prior approvals for the medications, such as rifaximin, that benefit these patients. And in this study, it looks like those people are APPs. So one of the findings that popped up that is somewhat controversial, I suppose, is that APPs are actually associated with reduced overall mortality. That this reduction in 30-day readmissions is not because mortality has gone up or transplantation has gone up in people who are seen by APPs. So overall, there's like a 0.6, 0.7 hazard ratio for mortality for people who are seen by an APP. If you go ahead and adjust for all of the confounders in the data set, you get an even better association with mortality. If you account for the competing risk of liver transplantation, the same. If you try to recapitulate the terms of a randomized trial balancing the covariates on either side of the equation to make sure that you're dealing with the same amount of encephalopathy and those were seen by APPs or not, in that propensity matched analysis, you have the lowest overall risk. And if you start the clock of survival at the diagnosis of cirrhosis, which could precede being evaluated by an APP, this sort of so-called landmark analysis, even in that very conservative way of cutting the data, you still see improved overall survival. So it is my belief that the best care that's provided is involved with collaboration between gastroenterologists, hepatologists, primary care doctors, which could very well include APPs. We're not the only people that looked at APPs. APPs are an incredibly valuable ally in the care of patients with cirrhosis. So that Shazia Sadiq, Dr. Sadiq, she was surprised by how many people were being admitted to the University of Pennsylvania with ascites. And she found that people with ascites were languishing in obsolescence in the emergency room, waiting for days, waiting for their hospital placement, because the emergency room is too busy to do a therapeutic paracentesis. I won't editorialize further. So she marshaled all of the stakeholders to recognize this as a problem, and they funded a rotation of APPs that would go down to the emergency room and perform that therapeutic paracentesis for the patient. And what happened after that is that she cut the amount of time that was spent by the patient in the hospital by more than half. Now, this is good for the patient, but it's also good for the hospital because this is the lowest value admission that I know of. I'd rather that bed be taken up by somebody who has an MI, sepsis, or requires a surgery. And so this is another way that APPs have improved the overall delivery of care to get people out of the hospital as fast as possible. Now, outside of the box, I have a couple of ideas that I'd like to share, and then I'll close for questions. So as relates to the management of ascites, the standard here is that we have to make paracentesis available to patients, but the medical therapy is basically diuretics and diet, okay? You have to get people to eat 2 grams of sodium or less. If you have symptomatic ascites, you're eating more than 2 grams of sodium. This is a physiologic fact. But getting people to eat lower sodium is super hard because they have to become sodium accountants. They have to have access to that food. And in real world practice, it falls apart. So I had an idea that I would actually feed a man. I actually sent medically tailored meals in a randomized trial to patients so that they could have a template to follow. They could know what low sodium food looks like, what it tastes like. And I guaranteed for at least 4 weeks while I was delivering them food that they would have a low sodium diet. And at the same time, both of the arms were getting repeated phone calls and education about diet. And so what did we find? We find that both arms have a reduction in the number of paracentesis per person week. Now, this was a pilot trial, not powered for statistical significance, but it gives you a pretty clear idea that if you actually go the extra mile and hold a person's hand through low sodium diet, both groups are going to reduce their overall paracentesis burden. But there is a signal that the food delivery is associated with improved outcomes. It reduced paracentesis, and it reduced improved ascites-specific health-related quality of life, and it actually resulted in a lower reduction in hand grip, potentially forestalling frailty for these patients. And so we're planning on doing a larger powered randomized trial of this concept. Now, I'm very interested in nutritional prophylaxis of complications of cirrhosis. And ascites is not the only one that's going to be sensitive to this kind of intervention. It turns out hepatic encephalopathy might be as well. So in the context of cirrhosis and portal hypertension, all of that ammonia that could cause encephalopathy begins its life in the gut and is shunted systemically to bathe the brain. So the best auxiliary mechanism when your liver is jacked up to deal with that ammonia turns out to be skeletal muscle. Skeletal muscle is a filter that pulls ammonia out and converts it into glutamine and protects your brain. So this process is catabolic. It costs branched chain amino acids to convert it into glutamine. And so hyperammonemia begets sarcopenia, and sarcopenia begets hyperammonemia. And for that reason, every society that's interested in nutrition or cirrhosis care recommends that patients with cirrhosis who have HE or are at high risk of HE eat at least 1 gram per kilogram ideal body weight protein each and every day. Now, eating that much protein is hard, just like it is to follow a low sodium diet. So we have launched the brain food trial. This one involves a slightly longer duration of medically tailored meals. It has as a primary outcome cognitive function using that Encephalopathy group, and we're also looking at physical function in addition to health-related quality of life. So we're about halfway through this, and I hope to present this approach at another time. But for the main takeaway point here is that one of the ways that we address encephalopathy is by making sure that our patients are not malnourished, that they are not on protein restriction, because that is the only way that we can support the homeostatic mechanisms that avoid the hyperammonemia that could result in an increased risk of hepatic encephalopathy. So the last thing I'll tell you about is caregiver support. So I actually think that the best prognostic sign for a patient is if they have a present caregiver, because that's the person that will hear the advice. That's the person who's does not have a waxing and waning mentation. They have a car that they can drive the patient to get to the appointments in a timely fashion to avoid hospitalization. But the problem is that this weighs on caregivers tremendously. Caregivers feel tremendous burden. They stop taking care of themselves. They lose their jobs. Their health conditions worsen. And so we have to come up with ways to support caregivers, and helping a caregiver feel present and refreshed to care for their loved one is, I think, one of the lowest hanging fruits in this particular field and instance. So Dr. Bajaj, he was the first to have this idea, and he actually enrolled patients and caregivers in a trial of compassion meditation led by a Buddhist monk. So he trained people to meditate, both patients and their caregivers, and he followed them pre-post to see what happened to their function. So patients with cirrhosis over here on the left, the meditation didn't change their MELD score. That doesn't surprise you. It didn't change their cognitive dysfunction because it's not magic, but it did change their burden of depression, reduced it tremendously. It improved their health-related quality of life measure of the sickness impact profile, and it improved their sleep quality. And what happened to the caregivers? The caregivers also reported decreased overall burden and improved sleep quality. So it's not clear if it's acting on them simply by improving the patient, but if your caregiver is going to sleep better and feel better, then there is no harm to this intervention. And I had, as soon as I read this paper, begun referring all caregivers to consider some type of relaxation response or meditation. But I've also started my own trial, in this case, a randomized trial, where I will explicitly look at patient outcomes, including 30-day readmissions, in the hopes that if we can support our caregivers better, it will be repaid with improved health-related outcomes for the patients. So what I'm doing is I am randomizing caregivers to one of three arms. One, a control arm where they just tell me how they're doing. their burden, their quality of life. 2, positive psychology. There was a clinical trial in medical residents, which asked them to fill out a few good things exercise. So write letters about something good that happened and why. And it was associated with decreased burnout in medical house staff. I heard that and I stole it and I put it in this trial. And then I also include, sort of as a positive control, a written emotional expression where patients will tell me something, caregivers will tell me about what worries them and why. They fill out these questionnaires, they do it for a couple of weeks, and then I follow their burden and I see what happens to patients overall. So my primary outcome looks at these caregivers, but I'm also looking at patients. And even though this is my clinical trial, in the practice where I'm not doing the trial, I'm still recommending that caregivers will write me letters or consider meditation or reading books about the relaxation response. So in conclusion, I would say that the way that we keep people out of the hospital is to identify the sources of success. You need to know about what kinds of factors to address that are going to be sensitive to readmission risk. And then when you implement them, you have to harmonize your goals with human factors. A checklist requires constant upkeep, but electronic order support does not. And I think it's time to get creative, that there's not going to be another drug that comes around that's going to reduce readmissions the way it was 10 years ago. So we need to think outside the box about the kinds of complementary therapies and approaches that are going to help us take care of the whole person as well as their caregivers. And with that, I'll conclude, and I thank you very much for your attention. Happy to take any questions at this time.
All right, that was fantastic. Thank you so much, Dr. Tapper. I do have a question for you. Out of, you covered several clinical trials. What type of cirrhosis patient it should be seen by a hepatologist? Where does the cirrhosis patient fall on the spectrum? And when do we refer to a hepatologist to help with the readmission issue?
Yeah, I think that's a very good question. And it also gets at the reality, which is that depending on the healthcare system where you are working, that the majority of patients may or may not be seen by a gastroenterologist at all. In the VA, the majority of patients with cirrhosis are managed exclusively by primary care. In Medicare, it's about half and half, and in commercial insurance, it's about 2/3 are seen by a gastroenterologist. And the minority of gastroenterologists are hepatologists. So that's why it's valuable to discuss these kinds of interventions in this setting, because you guys, internal medicine, primary care, are the front lines. Now, in terms of triggers for referral, so once cirrhosis is diagnosed, I think that is your first referral, because then you can have a plan that, if they're super compensated, might just include liver cancer screening, and that can be implemented from afar for years without any issue. But any of the decompensations, ascites, encephalopathy, or bleeding, this requires or does benefit from an evaluation by somebody who is professionally dedicated to cirrhosis. And with that, I'll just put out a plug for how to pick up on some of these problems. So ascites is rarely going to surprise you, okay? But encephalopathy can. And some of the subtle symptoms of encephalopathy are going to include multiple falls, or sleep-wake reversal, or a severe precipitous decline in work performance. And once you get that story in someone in whom you might suspect cirrhosis, that is somebody that ought to be evaluated, because starting treatment for encephalopathy can return someone to work. And so I would say the cardinal decompensations represent your primary trigger, but sometimes you have to search a little more deeply for them.
We have one question from the audience.
Hi, Dr. Tapper. Thank you for the great talk. I'm one of the internal medicine residents. I just had a question. Yesterday, we had two important trials that were published, the Confirm and Attire trials, and they were looking at the effects of terlipressin in HRS and also daily albumin infusions. And I know the conclusion said that there was no mortality benefit, but do you think there's any role for those therapies in 30-day readmissions for patients with cirrhosis?
Okay, so thank you for bringing that up. Yesterday was like the most exciting day to be a hepatologist. And if anyone hasn't read those papers, including the editorial by Dr. Garcia Sal, I would recommend that you do that. So in the management of type 1 hepatorenal syndrome, if you look at that paper, the average MELD score was like 33. Okay, these are people that are at risk of death or transplant, and that's it. Okay, so there's no readmission risk modifiability associated with terlipressin, and I'd be happy to discuss HRS treatment, but it's just not going to happen. Okay, for readmission risk. Now, the albumin question is more interesting. So that is a trial that was interestingly led by a clinical fellow, right? So this is that person's fellowship job was to run that clinical trial, and the first author in the paper is a fellow, fantastic. Okay, spending years doing that. And what they were trying to do is they were trying to improve the overall albumin concentration in the blood because it is felt that the higher your albumin level, the better your immune function. But unfortunately, it was associated with no decrease in the risk of infection, and it was associated with an increased rate in volume overload pulmonary failure. So by no means will that intervention, albumin for hypoalbuminemic patients in the hospital, ever reduce 30-day readmissions. However, there was a trial published in primarily out of Italy called ANSWER, which asked the question, what do you do for people with decompensated cirrhosis in the outpatient setting? And so there, it turns out that the Medicare of Italy, it actually pays for outpatient infusions of albumin. And so these people were getting twice weekly infusions of albumin, and then it went to once weekly. And it was associated with a reduced rate of death or transplantation. And so it is possible that in that more stable patient who is able to come to outpatient infusions, that albumin may be protective of things like hyponatremia and renal injury that could land you in the hospital. It's not clear because it's just one trial, not good enough to change practice. That paper, ANSWER, published 2 years ago now in The Lancet, and the first author is Caraceni, C-A-R-A-C-E-N-I, Paolo.
Awesome. I don't see any questions coming through on Zoom. And anyone else in the audience have any other questions? Nope. Okay, fantastic. Thank you so much, Dr. Tapper. And we will, I'm following you on Twitter already, and hopefully some of our residents will be shortly as well.
Okay. Thank you for having me, guys. Have a great day.
Thanks. Take care.